Welcome to the deep dive. For those of us really working in healthcare quality and safety, we know it's rarely just about one single incident, right?
Exactly.
Today, we're really diving into something bigger, the idea of the patient journey. It's this continuous, sometimes, really fragmented experience people have.
Mm.
And we want to explore how human factors and ergonomics, HFE, especially with this framework called SEIPS 3.0, is helping us understand and hopefully improve it.
And this is so relevant for, well, pretty much everyone listening. I mean, think about this. Nearly 60% of people in the U.S. have at least one chronic condition.
Wow, that's huge.
It is. And Medicare patients, for instance, they often see like 7 different doctors managing maybe 20 prescriptions every year. So this isn't just some academic idea.
Yeah.
It's the reality for millions.
Yeah.
And when that coordination fails along the journey, you get serious problems, things like hospital readmissions that could have been prevented.
Okay, so let's unpack that term then. Patient journey. What exactly are we talking about? It sounds like more than just, a list of appointments.
Oh, absolutely. It's much bigger than that. Basically, we define the patient journey as the whole flow, the sort of spatiotemporal distribution of a patient's interactions.
Spatiotemporal. So like where and when things happen.
Exactly. Where they go, over what time period, who they interact with, doctors, nurses, sure, but also family, friends, caregivers at home. It captures how care actually happens across all these different places.
So it's like mapping out their entire healthcare experience, even the parts outside the clinic walls.
Precisely. Think of it like a personal healthcare travelogue or maybe a photo album of all their interactions. It really frames healthcare as this ongoing story, not just separate snapshots.
That travelogue idea really resonates.
Right.
Makes it feel much more personal. Okay, so if it's this complex journey, how does HFE, human factors and ergonomics, help us make sense of it? That's where SEIPS 3.0 comes in, you said.
Yes, exactly. SEIPS 3.0 gives us a lens. It's what we call a socio-technical systems approach.
Okay, break that down a bit. Socio-technical.
Right. It means we don't just look at the people involved or just the technology or just the environment in isolation. We look at how all those things interact constantly as part of a whole system that's always adapting.
Aye.
So the patient journey isn't seen as just, point A, then point B. It's a series of linked work systems, could be the ER, the GP's office, the patient's home, that connect and change over time.
And you mentioned the sharp end and blunt end.
Yeah, that's key in SEIPS. The sharp end is that direct hands-on interaction. The nurse giving a patient their meds, the doctor doing an exam.
Okay.
The blunt end is, everything behind that. The hospital policies, the staffing ratios, the design of the electronic health record, even the lighting in the room. All those background factors that shape what happens at the sharp end.
Gotcha. So a mistake at the sharp end might actually stem from something way back at the blunt end. It connects the dots.
Exactly. It helps reveal those hidden influences on safety and quality.
Okay, let's make this really concrete. You mentioned a fictional example, Kathy's story. Moving from a rural ER to a big hospital, then a nursing facility, then PT, how does SEIPS 3.0 help us understand her journey specifically?
Well, Kathy's story is a perfect illustration of what we call transition work. It highlights those critical moments between different care settings.
The handoffs?
The handoffs, exactly. These interfaces between organizations are where things often break down. Information gets lost, communication falters, responsibilities get blurred. They're real points of vulnerability.
Sounds incredibly risky.
They can be,
Yeah.
but there are also chances for the system to show resilience, for people to catch errors if those transitions are designed and managed well. It really shows how the journey is like a chain, every link, and especially the connections between links matters enormously.
That really drives home how complex this is, especially at those connection points.
Yeah.
So thinking about designing for safety, what are the biggest challenges for human-centered design when you're looking at this whole messy journey?
Yeah, there are some major hurdles. I'd say there are 3 big HFE challenges. First one is dealing with multiple perspectives, meaning you have to bring together so many different people, patients, family caregivers, doctors, nurses, therapists, administrators, all across different places. And they often have different needs, different priorities, maybe even conflicting goals, and different levels of power, too. Designing something that works for everyone is tough.
Okay, that makes sense. What's the second challenge?
The second is achieving genuine participation. How do you actually get all those different people truly involved in designing better systems? We're talking beyond just surveys, maybe things like citizen science approaches.
Citizen science and healthcare design. How would that work?
Well, imagine patients actively contributing their own experience data, maybe helping analyze it, or even co-creating solutions alongside clinicians. There was a great example, redesigning family rounds in a children's hospital, really involving families. Deeply made a huge difference. It takes effort to make participation meaningful, not just a token.
Right, not just ticking a box. And the third challenge?
The third is working at the interface. As we saw with Kathy, care jumps across boundaries all the time. Organizational ones, geographical ones, sometimes cultural or language barriers, even just gaps in time.
Mhm.
We need to understand how problems or system barriers can sort of ripple through the whole journey. A study on medication management for older adults going from hospital to home health really showed this. You need people, processes, maybe technologies that act as boundary spanners, things that actively bridge those gaps and help connect the different parts of the system.
Boundary spanners. I
Yeah.
like that. Okay, so bringing this all together then, this deep dive into SEIPS 3.0, it really seems to show that if we want real patient safety, real quality, we can't just look at isolated moments or single clinics.
No, you really can't.
We have to take this wider view, this holistic look at the entire patient journey, right? Connecting the big picture, the blunt end stuff with those sharp end interactions. It's about building a system that's truly human-centered from start to finish.
Absolutely. And that leads to, I think, a really important question for you, for anyone listening. When you or someone you care about is navigating the healthcare system, how conscious are you of all these different interfaces, of the hidden work that goes into connecting those dots?
That's a powerful thought.
Yeah, and how can really understanding this idea of the patient journey empower you, empower all of us to advocate for care that's more joined up, more seamless, and, well, more genuinely human-centered, recognizing, that every single step along that path truly matters.